Well, hello and welcome to today's episode. I'm really delighted to be joined today by my friend Professor Valter Longo. Valter is the Edna M. Jones Professor of Gerontology and Biologic Sciences and the Director of the Longevity Institute at the University of Southern California. And he joins us today from his base in Los Angeles. You're very welcome, Valter.
Hey, thanks for having me.
It's great that you're here, and what I really wanted to, you're very well known to this audience, I'm sure, with your work, your groundbreaking work, connecting fasting and nutrition with all kinds of health issues, including healthy aging, longevity, and many diseases. And I suppose being an oncologist, I'm particularly interested in probing some of your work on cancer and fasting. But before we get to that, I really want to, in deference to the times that are in it, ask you about how the COVID-19 crisis and pandemic is affecting your work.
Of course, it's many laboratories are shut down. Ours is not, in part or particularly because we have always worked on immunosenescence and viral protection against viral infections and boosting of the vaccination, boosting of the efficacy of vaccination, particularly with the flu. So the grants we've received so far had to do with the flu. But of course, now we're hoping that as soon as the COVID vaccine is available, we can start also focusing on COVID-19. To me, it hasn't made much of a difference. I still go to work every day, but and maybe a third of my lab still comes to work, and in Milan, it's about the same. About half of the lab continues to work, and half had to stop because of COVID.
Yeah, I think Milan got particularly badly hit by this epidemic, and I'm sure your colleagues there were very badly affected over the last number of weeks.
Yes, Milan was fairly bad, but I think areas like Bergamo, Brescia, Cremona, some of the smaller towns in Lombardia and Emilia-Romagna, I think they were doing much worse, and some of the hospitals being overwhelmed, not enough respirators and people in the hallways, and I just heard that in some places it's still going on. So interestingly, so Milan wasn't so bad, probably because Milan was more organized, but some of these other nearby cities were affected pretty roughly. Yeah.
I might come back to the connection with COVID-19 again in reference to your work, but I'd like to begin by focusing in on exploring the connections between nutrition and cancer. And maybe if I could ask you to just start with maybe the connections with cancer biology. And we've known in our world for many years that insulin and insulin-related hormones are particularly important as growth factors in very many cancers, and other pathways, including mTOR and so forth, are also known in our world as very important targets in cancer drugs and cancer treatment. Maybe you could just tell our listeners a little bit about the connections between that and nutrition.
So, well, I don't think it's really about nutrition. I think nutrition just happens to be a tool to generate a complex environment for the cancer. And what I mean is actually a differentially complex environment, meaning that the environment has to be complex only for cancer cells and not for normal cells. So it doesn't really need to be nutrition. It could be anything. It could be heat. It could be cold. It could be, but it happens that nutrition fits perfectly that definition of a differential environment, meaning that cancer cells in most people have, or let's say almost everyone, have evolved under abundance of nutrients. So there's a lot of sugar, a lot of amino acids and proteins and vitamins, etc. So the cancer cell doesn't really, unlike a normal cell that is the result of billions of years of evolution, doesn't really understand starvation. In its short evolution span, and never had to experience that. And so, in fact, not only doesn't understand starvation, but it rebels against starvation because it says, it makes a decision. It doesn't matter what the environment is, I will not respond, right? That's the definition of a cancer cell, unresponsive to anti-growth signals. So that's what we're exploring. So whether it's, you mentioned insulin, IGF-1, ketone bodies, glucose, and leptin, et cetera, et cetera, et cetera. So all of those are changed drastically during starvation and during fasting. But the body, whether it's a human being or a mouse or any organism that you can think of, understands that, at least for up to a certain point. For the human body, that point is a month and a half to 2 months, right? So most people can go a couple of months without any food and just a little bit of water. So then that's what we're trying to exploit. So how do we stay very far away from those 2 months and keep it maybe 5 days, 4 days, and put the cancer cells in a very tough situation, so that then any therapy, whether it's chemotherapy, kinase inhibitors, radiotherapy, and now we're investigating hormone therapy and et cetera, that's gonna make him then go from bad to worse. And the idea is then to combine with standard of care. Why? Because standard of care, in most cases, it might be the result of, so let's say in prostate cancer, you're targeting the cancer with hormone therapy. Well, that's a result of maybe 100 years of research on prostate cancer, right? Or certainly at least 50 years. And so we want to take advantage of that, because whatever therapy, it works up to a certain extent. But then the fasting and fasting mimicking diets come in and make it and bring in this differential stress. And that's what seems to be very effective.
Well, I can imagine being an oncologist, and I can just tell you, when up until I started reading your work and thinking about these pathways, the notion of subjecting a cancer patient to starvation or fasting would really have been considered foreign to the average cancer doctor, I think. So I imagine when you explored that with your colleagues in the clinic, you may have experienced some resistance. I mean, we would normally be telling people, up until recently, I would have been telling people to eat as much as you can, especially during the course of your treatment, to, quote, build up your strength and make sure you can get through, more effectively. So when you started to work with your clinical colleagues, what was the reaction you got when you suggested that you might want to restrict feeding and fast patients?
Yeah, so at the beginning, of course, the oncologists were all almost unanimously against it. And more than the oncologists was the dietitians and the nutritionists. Everybody was against it. The surprising thing was that the people that were working on fasting were against it, right? So even the fasting clinic, there was one thing in the Russians, they were doing fasting for a long time. There's one thing in the, I think, Russian National Academy booklet that they say that never use fasting against cancer. That's a bad idea. So we pretty much had everybody against us. Now it seems like, it makes sense and everybody agrees with us. But no, at the beginning, almost unanimously, everybody was against us. Now we were lucky enough at USC with David Quinn and Tanya Dorf. They were skeptical, but they listened to us and they said, okay, let's start with 1 day of fasting. Then we moved to 2, then we moved to 3, and we did it like that. It took us forever. But eventually, I think that was like 12 years ago. That's how we got started. And, eventually, now lots of people are still skeptical. Somebody came to me the other day with an advanced stage disease here at one of the big hospitals in Los Angeles. And the oncologist said, absolutely not, no fasting mimicking diets for my patients, right? So it's still there, and I think I like to think that this year is going to be the end of the beginning. We have a number of clinical trials that are going to be published on fasting mimicking diet and cancer treatment, and I think that it's going to make a difference. Not that it's going to become standard of care, but that lots of oncologists all over the world are going to say, yes, this is part of my toolkit now. And I know I can use it if I need it.
Could you give us maybe an idea of the main studies, clinical studies that are ongoing, and what conditions, and when do you expect the results of those trials?
So the one that is going to be published in about a month or less is a 12-center Dutch study, breast cancer, and these are patients that underwent up to 8 cycles of the fasting mimicking diet in combination with chemotherapy. And then they underwent surgery for breast cancer. So that's going to be published very, very soon. And then there's going to be 2 more trials that are going to be published very soon. One is sort of open trial at National Cancer Institute in Milan, looking at using the fasting mimicking diet with all kinds of cancers, whether it was immunotherapy, chemotherapy, radiotherapy, various inhibitors, etc. That's going to be 93 patients. The one in Leiden is going to be 125 patients randomized. And the one in Milan is 93 patients. And this is interesting because we're going to start again, take a look at how it works with the different combinations, with the different therapies, and also how it is safe with the different therapies. Then there is another one in the University of Geneva, and I'm a co-author on all of them. But that's going to be between 75 and 90 patients, again open. Lots of, for example, hormone therapy, breast cancer hormone therapy cases. That's going to be interesting. And by the way, 36 of those patients, we're going to see the publication within, let's say, 2 months. So within 2 months, we're going to see 2 publications: 125 patient breast cancer from Holland, and another one on about 36 breast cancer hormone therapy patients from Milan and Geneva. And then we have a trial with you, and your trial, in which we're also a collaborator. And we're very excited about that, and I think we as you know, we try to expand it now. I talked to the oncologists here, the prostate oncologists here, and they're excited to move forward. So pretty soon we're probably going to do a 4-way call with you, and so that we can discuss. You have a trial going on with 30, 40 patients, but I think we want to move it to the next level, maybe 200 or 300 patients. Hormone therapy and prostate cancer, and see, if we can again move it to the level where oncologists all over the world just say, yes, I'm convinced, or not, that this is the way. This is something that I want to include in my treatment.
So that study you're referring to builds off a pilot we've been delighted to work with you on in men with prostate cancer who have a requirement for androgen deprivation therapy, or what we often call hormone blocking drugs, in conjunction with their other treatments. And those hormone blocking drugs induce a metabolic syndrome in these patients if you leave them on it long enough. And so we have been looking at your fasting mimicking approach to those patients, and we're seeing some encouraging results. So we'll be delighted to follow up on that with you. On most of these studies, Valter, are the endpoints measured toxicity related, or are they survival related, or disease-free survival, or what sort of endpoints? I know you have a variety of studies, but are you hoping to see improvements in remission rates and disease-free survival with these approaches, or is it about reducing toxicity from treatment?
No, it's definitely about, I think we have the ambition of immunotherapy, if not more. So the ambition is to, first of all, is starting to look from preclinical, and now we used to be the only lab working on this. Now there are many labs and many publications in mice. So now, for example, just a very nice publication from a Spanish group looking at immunotherapy for lung cancer, and how fasting in mice made it a lot more effective, made the immunotherapy a lot more effective against lung cancer. So it's now lots of labs are doing it, and we think it's moving towards a more of a standard use in the clinic. But we still have to wait and see a number of these clinical trials, and and see what happens. Yeah.
That's very exciting. If I could maybe bring you back a little bit to the topic of COVID-19, I'm sure you've been seeing, there have been reports in Nature and other journals pointing to the fact that one of the biggest predictors of poor outcomes for patients affected with the virus seems to be their metabolic health, and the presence of obesity and metabolic impairment seems to be a predictive factor for very poor outcome, right up there with age. So do you see, is there any thought to maybe looking into some of that, given that this is so topical right now and that there's so few therapeutic options here in patients with this virus?
Yes, well, first of all, the number one risk factor is age, right? So for COVID-19 mortality, there's a big difference between probably around 100-fold. I mean, don't quote me on it, but it looks about like that. Like we say, between a 30-year-old healthy person and an 85-year-old sick person, there looks to be about 100-fold difference in risk or so. And so then definitely age, rejuvenating the immune system. That's what we've been working on, right? So how do you bring the lymphocyte number back up, and how do you make the immune system function properly and not overreact, for example, right? So one possibility that we heard from Italy from some doctors is that it is an inflammatory related death, right? So I mean, I don't know. I'm not making a statement here, but certainly that there is this possibility, and this could be. It would make sense that somebody who's overweight and somebody who's sick might have a higher inflammatory state, or maybe more prone to an inflammatory state, or maybe less able to withstand a burst of inflammatory response. And so that, together with the aging component, I think is a recipe for disaster, and that's why we're seeing such a high mortality. So I think it's good to. I mean, in our case with the fasting mimicking diet, we're working on both, right? So soon enough, we're going to publish on the effect of cycles of the fasting mimicking diet that you're using, also on biological age. So the question is, does it bring back biological age? Does it make people younger biologically? And then, of course, we're going after the obesity, we're going after the metabolic syndrome, we're going after the hypertension, all the additional risk factors that seem to be very common among COVID-19 patients. So this brings us right back to what we've always said: treat aging, right? So we say there is a focus on Band-Aid medicine, where you wait until somebody's sick and then you intervene in a million different ways, doing sometimes good, sometimes not so good. And now we're saying treat aging first, because then you're never going to have to deal with that. So, for example, we work on mice that were generated by Andrei Barkey and John Kopchik that lack the growth hormone receptor, and also on people that lack the growth hormone receptor. And in both the mice and people rarely get diseases, right? The humans that we've been following in Ecuador, out of 100 people that we followed, myself and Jaime Guevara, the endocrinologist, in 50 years of him observing them, there's been one single cancer, and they get to pretty old age, right?
They don't restrict their other risk factors either, I gather, from reading about this work before. They're not particularly healthy in other walks of life.
They're overweight or obese. They have a poor diet. They smoke. They drink. They don't exercise. I mean, if you have to think of a group that would die of all kinds of cancers and cardiovascular disease and diabetes, that's a group, and you almost never see that, right? So this is telling you again, treat aging is the way to go for the majority of people. It doesn't mean that for example, mice. About half of the mice still develop during the life some type of diseases, right? But that's compared to 90 or 95% of the control mice. That's a big difference, right? And if you look at cancer, it's much lower even in the mice, right? So this is why when you start seeing these parallels between mice and humans by a single mutation, which happens to be the one that controls aging more than any other, the gene that controls aging more than any other gene, then I think you get a good sense of this is it. That's the way to go.
So I know that in addition to your work in the laboratory and with collaborating with clinicians, this is something that you've taken into your own life, and I know you've written a book on this topic. So do people need to do fasting mimicking diets to gain these benefits, or are there other nutritional programs that I promised my aunt, who's 93 years of age and in rude health and a big fan of yours, that I would ask you if there was anything particularly she should do with her diet. At this stage, I said probably not. But so do you take all this work into your own life as well, and as to how you live and eat? And
yeah, I have a story. So Emma Morano, who I followed personally, and she got to 117. I think she was like 105. And a journalist came, and she was eating red meat every day. And the journalist said, "Oh, don't you know that red meat causes cancer?" And so she's 103 or something like it. And she went to their doctor and said, I'm very worried, that this is what this journalist told me. So yeah, obviously at 93, you don't have to, probably you don't want to change your diet. It's okay. And in fact, what we published a few years ago was that we believe that lots of the centenarians in Italy, and including Emma Morano, might have benefited from this dual nutritional situation where up to age, say, 75, 80, they had the old poor Mediterranean diet, little protein, almost no meat, once a week, et cetera, et cetera. Then eventually they moved in with their sons and daughters, which were eating much worse food and much more food, right? And we think that actually increasing the protein intake when they got older, increasing the meat, the eggs, Emma Morano was eating 3 eggs a day and 100 grams of raw meat per day. But the 100 grams, I think she started about age 100, right? And her doctor, Carlo Bava, might have very well kept her alive between age 100 and 117 by being very strategic and doing sort of the opposite of what you would do in somebody younger, right? And so the nourishment now becomes so important and more important. Say the nourishment, the immune system is feeding the immune system, which is now fighting something like the flu, right? Lots of old people die of pneumonia, die of the flu. They don't necessarily die of cancer. So yeah, so I think that at older age, I think I talked about it in the book, The Longevity Diet, and but I think there's clearly different phases of life, and in different phases of life there is a different nutrition. And I think up to age 65, 70, the pescatarian diet, everyday pescatarian diet is ideal, say vegan plus fish a couple times a week, with the maybe 3 times a year, the fasting mimicking diet. Then after that, the fasting mimicking diet, I think should only be given to people that need it. Like, for example, we have an Alzheimer trial in Geneva ongoing now, it gets to up to, I think, age 85. And so in that case, we're increasing the calories, but still giving them a fasting mimicking diet once a month, and we'll see what happens. So I think that pescatarian diet and 3 times a year, the fasting mimicking diet, then just the pescatarian diet. But then I think every day an 80-year-old should probably start eating more fish, more eggs, maybe even some yogurt. And so the nourishment now becomes very important. And if you look at people after age 65 or 70, they start losing weight, right? So, and the extra fat seems to be actually beneficial and not detrimental. Not a lot of extra fat, but a little bit of extra fat, the same extra fat that may put you at higher risk at age 40 for metabolic syndrome and cardiovascular disease, at age 80 could be beneficial.
Yeah, and you and I have talked about the prostate cancer patients, that the small sample of 30 plus men that we have been involved with together, they certainly report very substantial improvements in their quality of life as their metabolic parameters improve on this program. And very many of them voluntarily change the way they eat without us advising them to. They just sort of all of a sudden figured out that too many carbs were not so good, and they made changes in their own diet that seemed to be allowing them to maintain the benefits even past the 3-month cycle of the study. So that's really encouraging for us.
Yeah, in research we have something that's called food aversion, right? So mice, they can become, and people, they can become disgusted with a certain food because they associate that food with something very bad, right? Let's say an electric shock or whatever. And so now we're starting to suspect that the opposite is also true, where if you are on a vegan, prolonged fasting mimicking diet, and you start now associating these 5 days with lots of benefits, and your brain may begin to search for that component which you never understood before because you never ate a vegan diet for 5 days, and let's say a fasting mimicking diet for 5 days. So that's what we suspect. We see this very, very commonly in those that do the fasting mimicking diet. They slowly move towards a healthier diet, a more vegan diet, and it may come from the education of the brain to the positive effects of that particular nutrition, because you're not doing it for a few hours. I mean, if somebody has a vegan meal, that probably doesn't change things very much. But being sort of forced for 5 days to have 100% vegan meals, low calorie, I think it re-educates your system metabolically, but also potentially at the psychological level, so that you seek those types of foods, and eventually you also seek maybe the ketogenesis state, which was very common in our past. So these ketone bodies and fatty acids, they will get to very high levels, and most people. So we suspect, we don't know for sure, but lots of people get headaches particularly the first time they do the fasting mimicking diet, and we suspect this might be the first time their brain is activating certain enzymes that are generating or processing ketone bodies. Like they've never used them before, so they might be 55 years old and never once have used these enzymes in the brain that are involved in ketogenesis.
Yeah. Well, Valter, the work is really exciting. We're looking forward to completing this pilot study with you and getting the data analyzed. And I'm going to ask you if maybe in 3 to 6 months we might have another discussion when we can hopefully share some of that data and move on to some of the trials we can do as a follow-on. And I really want to thank you for your time today and for your work and the opportunity to collaborate with you. It's been most exciting, and I look forward to seeing you again very soon.
Thanks, and great collaborating with you.